First, I want to say thank you all for coming, and it's really heartening for me. We have been doing a lot of these community forums actually for the last couple of years, whether I've done it for the state or for the agency I'm working for now. This is clearly the best attended forum that we've had, and I hope that speaks to the fact that we are getting more and more information out there and that people do have more questions and concerns about this, because this really is, as I see it, a public health crisis. I'm going to speak specifically to the question of why so many people are using, but I would say that I want to look at that from the three different areas that I see as being critical to this. So one is prevention, one of the main reasons we're here. Next is treatment and access to treatment, and I'll talk about a little bit about that. And then I wouldn't be doing my job or doing what I like to do if I didn't talk about the impact of discrimination on the individuals who struggle with this issue, their families, and others involved. And I just see that Congresswoman DeLaura arrived, so I'm going to be quiet for a minute.
Final note, last month the New England delegation, all of us sent a letter to Secretary Burwell of the Department of Health and Human Services expressing our concern over the growing opioid epidemic in our states. In the letter we proposed to a working group to identify ways to reduce prescriptions for opioid painkillers, to expand prescriber education, and examine non-opioid approaches to patient treatment, alternative pain management. I believe these are programs that are critical to curb drug abuse and overdose, as are the forums like you've had here this evening. So, armed with the information we have from tonight's briefing, I think we can all do our part to fight against opiates in this community and address what has become a critical and a crisis epidemic proportion. So I thank you. I thank you for allowing me to be here and for saying a few words, and anxious to hear from the panel. So thank you.
So again, I think there's three areas that I want to speak to: prevention, treatment, and some of the issues around discrimination. So from a prevention point of view, these are the kind of forums and these are the kind of conversations we need to be having. And if you are parents, these are the kinds of conversations you need to be having with your children. There are two things that are really, thank you, striking. Everybody hear me okay now? If an individual does not use any substances, including nicotine, so let's just be clear, before the age of 18, they have a 90% chance of not becoming addicted to substances for the rest of their life. 90%, even with genetic loading. If we can keep young adults from using substances until the age of 21, that percentage goes up to 96%. And again, if you're from a family like mine that's genetically loaded, I can tell you that I had those conversations with my kids from the time they were in the end of elementary school, is that what we're still calling it? But certainly by middle school, you need to be having those conversations. We know from the overdose deaths in this state that we are seeing individuals 14, 15 that are dying from overdoses. This is not just a young adult problem. Substance abuse is actually, as Dr. Allen I know will talk more about, a disease of adolescence. We need to try and nip that in the bud. In terms of treatment, we do have treatment available. There are treatment centers all across the state, like Rushford Center, like others, who treat individuals that are addicted to any substance. But we are seeing increased need for the treatment of individuals who are addicted to opioids. I think that there is access. As we continue to have these conversations, I hope we'll need more access, frankly, and more treatment. In my opinion, one of the things that keeps people from going to treatment is the fact that this is still a group of people that are largely discriminated against. That goes for all of behavioral health, but certainly people who abuse opioids. There is still the notion that these are people that may come from the inner city, that come from poverty. We know those facts are no longer true. I looked at the entire state yesterday in terms of the number of individuals being admitted for treatment in the last year. There was not a city or town in the state of Connecticut that was not admitting people for this problem. That's the good news in some ways. The bad news is when people don't seek treatment because they don't want people to know. I was sharing with somebody today, and I don't remember where I heard this story, of a young man that went to his parents and said that he was addicted to opioids. They thought he was talking about prescribed medication. They were upset, but agreed to support him in getting treatment. When he said, well, I'm actually addicted to heroin, the parents' reaction was much different. Because again, stereotypically, that means somebody that's shooting, and by the way, there's a lot of ways to use heroin, not only shooting it with a needle. Young adults more and more snort heroin, especially in the beginning. So the idea that it's the old needle in the alley is long gone. So again, I think that what the community has to do, what people like we all have to do, is get the message out there that there are individuals in every community, as we speak, that are dying. The increase in overdoses in this state, as Congresswoman Dolores said, has gone up since 2012 exponentially, but even between last year and this year, there's been at least 20 to 40 more individuals. It's really hard to get the numbers straight because it depends on whether it's all opioids or just heroin or just pills, so it's a little hard to get the numbers exact, but they continue to increase and continue to increase in this year at a very alarming level. The other issue is that we know, again, 18 to 26, very, very high-risk age group. That is an age group that we are seeing seek treatment more, which again is a good thing. But the other age group that we are seeing die from overdoses is middle-aged white women. And that's primarily related to the idea that they go to the doctor, they have surgery, they get pain medication, and then they become addicted to it. And I suspect that that demographic is a little bit better at doctor shopping than perhaps some others. I do want to also recognize, though, the legislation in this state that I think has impacted enormously and will continue to impact. So in 2012, I believe the first bill was passed that allowed the family or friends of somebody suffering from addiction to get the drug Narcan, which saves people's lives. If somebody is overdosed and they receive a dose of Narcan, there is a much higher probability that they will live. That, I have to say, having been the commissioner then, didn't work terribly well. We didn't find a lot of physicians who are actually willing to write those prescriptions. I think that perhaps we didn't do a good enough job educating people. There is an issue about prescribing for your sister instead of the individual client, so we had some issues. The following year, another bill was brought forth that expanded the Good Samaritan law so that if you were somebody that administered Narcan to somebody, you wouldn't have charges pressed against you. Unfortunately, that didn't work either. This past year, there was a very important bill that was passed, one that will allow pharmacists to dispense Narcan without a prescription. They'll be required to do education, but they will be able to do that, and I know that the Office of Consumer Protection is working on that now. The second part of that legislative bill was the doctors are now, I want to say forced, because that sounds really awful. They are compelled to use a prescription monitoring program, which is a federal program that's been around for many years, but doctors had to register, they didn't have to use it. What this will do is have doctors go in and look at what other medications somebody may be on, or whether there are 3 people prescribing oxycodone for the patient that's sitting in front of them. I think it's very, very important. And I'm forgetting the third part of that legislation.
Education savings.
Oh, that's right. And the third part was that physicians will now be required to take continuing education for the prescription of opioids to ensure that everybody understands the implications behind giving somebody 30 tablets of Vicodin when they've had a tooth extraction. There are really good reasons for pain medication. I don't want to see the pendulum swing too far the other way. People need pain medication, but we have to be really thoughtful about how it's prescribed, who it's prescribed for, and the kind of education we should do for that individual. And I think that's it with my time, so I'm going to hand it over to Peter McShane.
Thank you, Pat. Again, I'm Pete McShane. I'm the state's attorney here in Middlesex County. I can tell you this, I've been in the business as a prosecutor for 27 years. 23 down in New London, and 4 here as the state's attorney for Middlesex. It's my understanding, if you listen to the media, that crime is down. All statistics are down. Quite frankly, we're not feeling that at all. The crimes related to heroin users, abusers, those crimes are up. And it may not just be straight possession crimes, but it's what we call spillover crimes. I can tell you this, every day in the courthouses throughout the state at 10 o'clock, the judge will advise those in the courtroom as to the advisement of rights. They'll also bring up those from lockup, and at that time the judge will advise them of rights. When I was a young prosecutor, I would sit there, that was many years ago, I would sit there and play, guess the crime game. And you look down the line, and so you look at Paul Doyle and you say, there's a problem there. But you wouldn't know exactly what the problem was, but you could say, all right, that looks like a domestic, that looks like an assault case, that looks like a heroin case, because you knew what heroin users looked like. Not so today. Today you look at that same group of people, and you could have a soccer mom, you could have a former high school athlete, you could have a professional. And the last crimes in the world you'd be saying 20 years ago was heroin, 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 but that turns to be the case today. So we are seeing a significant amount of heroin users, and it really, it has no bounds anymore. Before it was an inner city crime, it was limited to a small community of people, but now that has expanded. I was told to speak about where the narcotics are coming from, and right away I said, blame Hartford. They're all coming from Hartford. We don't have them here in Middlesex County, but then I was told that the question was, are they coming from Central America or South America or wherever? I don't know where they're coming from, but I will tell you this. If you were to go out right now and to buy a bag of heroin here in Middletown, it would cost about $10. That same bag of heroin would cost $4 in Hartford. So if you're a heroin seller, you can come down here. We've got great restaurants here in Middletown. You can enjoy a nice day out in the country and make a heck of a profit. Now, we saw that happen with crack, too. Crack down in New York, you could sell it for $5, $2, $3, but if you took a train ride up from New York to New London, you could double or triple your profits. And that's what's happening here. We're getting a market of dealers coming down and sell. From a law enforcement standpoint, that's very difficult to investigate. They come in, sell the wares, and they're back the next day. But we are working on it. When I talk about the spillover crimes, we do have an increase in domestic violence cases. We do have an increase in DUI or operating on the influence cases. And to the point that now, we're shooting for it in Middlesex County, we have officers. Any officer could give the standardized field sobriety test. There are special tests that are given with regards to telling if someone's drug impaired. Middlesex County, we only have one officer. We're trying to get more officers that are able to do these drug impaired tests. We have to actually bring them in. We had a case in East Hampton. A woman was hit on a sidewalk at 5:30 in the morning by somebody who was drug impaired. We had to bring up a cop from Norwich in order to do the tests, and sure enough, she was under the influence. We do have, we also notice in our larceny and burglary cases, years ago, you get a house burglary, you would sit back and say, okay, look at the electronics, see what was stolen. Now people are going into houses just for the, cops are going in, and the first thing they do is look inside the medicine cabinet, see what was stolen. You're getting a lot of those cases where it's something we didn't think about 10, 15 years ago. I do want to go over the statistics. In 2012, there were 174 overdoses. Of those, 14 cases, fentanyl was involved. Now, we all know about the dangers of fentanyl. Look, the people making this heroin, they're not exactly chemists at Pfizer. They're being made, and they're adding substitution, they're adding fillers, they're adding stuff that increase their profits. Fentanyl is one of those things that are put in there. Fentanyl-related deaths increased from 2012 of 14 up to 92 last year. And as Congresswoman DeLaura told us, it's 3 times the amount of deaths in 2015 that there was in 2012. Now, here in Middletown, we have a wonderful university, some of the smartest and brightest kids around, and we had a lot of overdose cases there last year. We had 12 of them. It wasn't opioid related, it had to do with MDMA. But these smart kids were going on YouTube with test kits, telling the other students, telling the other purchasers, look, this is safe, this has got this in it. Look, here's a test kit that proves that this is Molly or MDMA and this is good stuff. You know, what those test kits don't tell you is what else is in there. And it's bad stuff. It's not good. I mean, they could put baby powder in there. You know, if you take a gram, or we'll say an ounce of pure heroin, and they call it step on it. If you put stuff in it, you could increase it. If you put baby powder in it, instead of having just the 1 ounce, you've now made it 1.5 ounces. If you put fentanyl in it, you now went from 1.5 ounces to 2 ounces. You've increased your profit share, but by having more product. So, you know, although these kids are extremely bright, what they're doing is just stupid because they don't know what else is in there. Yes, you're going to get a positive test that there is heroin or MDMA or something in there, but it's not going to tell you what else is in there. So what are we doing in the courts about it? There's been a lot of talk about second chance society, and quite frankly, we've been doing that all along. Possession of narcotics now has been downgraded to a misdemeanor. That helps somebody down the road when they're applying for a job. We need immediate help now. Now I'll tell you this, everyone in this room believes, you know, heroin is a big problem. And nobody looks at a heroin addict and say, well, forget him, just lock him up. And we don't see that over in the courthouse either. The problem is when that heroin addict does more than just obtain heroin. When they're breaking into houses, when they're assaulting people, when they're driving under the influence. So the heroin may be at the root of the problem, but it's those spillover crimes that land them in jail. We're not sending people to jail for victimless crimes. If we are, it's because we've given them so many chances to improve. You know, years ago, when I started, you came to court, if you had a felony charge, the judge would recommend a bond. Now we monitor people. I mean, that's probably, if crime is down, we probably, by 10%, we probably spend 30% more time in the court system monitoring people, whether out on pretrial release or subsequently after conviction. So we're doing what we can. It's just difficult. It's a difficult addiction. We know that. But we've been working with people, and quite frankly, we're not doing enough. And we know that. We know that because the stats keep going up. And you know, if anyone has any suggestions, I'd be happy to hear it. But we're doing what we can in court. And you know, everybody says, you know, that person has a heroin problem, but then it becomes society's problem when another crime is committed, when a spillover crime is committed. And that's when people get outraged. Well, why isn't that person in jail? They've been given countless opportunities. They're an addict and they've been given countless opportunities. We're trying to work with them. And I know at times that the prosecutor's office may sound like social workers when it comes to that, but really, this is the type of crime where we need a little social work. And we're doing it. Perhaps we're not doing it well enough, but you know, with cooperation like we have here tonight, hopefully we'll get better off. So that's all the time I have. Thank you.
I'm Dr. Rehmer. I'm the medical director at Rushford. I just wanted to mention, Attorney McShane was talking about fentanyl. Fentanyl is 30 to 50 times more potent than heroin, so when someone is, if they think that they're using heroin, or even if they know there's fentanyl in there, their body is unprepared for that type of a potent punch, and that's one of the reasons that we've seen more of these overdose deaths of late. I want to start by pointing out that no one chooses to become addicted to an opioid or addicted to any other type of drug. Addiction is a chronic disease, and like other chronic diseases like hypertension or like diabetes, it's recurring. If someone is lucky enough to get into treatment, that doesn't mean that they're going to be cured, and they may need to have a second round of treatment. They'll definitely need ongoing monitoring, and sometimes people lose track of that. I've had families come to me and say, Will he be cured when he gets out? And unequivocally, I say no, he won't be cured. The changes that take place in the brain can be long-lasting. The most vulnerable population is the population where addiction begins. And like many other mental health disorders, addiction is a developmental disease. It begins in adolescence. And that's where people who are first exposed to substances that have an impact on the part of the brain that has to do with the reward system, the nucleus accumbens. This is when the changes take place. And there's more and more evidence that shows even casual use of substances when you're, as Pat Rehmer was saying, before the age of 21, before the age of 18, can make long-standing changes in your brain. This is in part because the brain is not fully formed until you're at least 21 years of age. And all the studies and the research and the functional MRIs are showing that if you start using any addictive substance before your brain's fully formed, you're going to be vulnerable to developing a substance use disorder when you get older and further down the pike. So in some instances, you may see someone who it doesn't have an active substance use problem and they're 27, 28, 35 years of age, but as an adolescent, they may have struggled with marijuana use or alcohol, or even probably most likely cigarettes, smoking, and nicotine can have the same type of impact. And then they're exposed at the age of 35 after some sort of traumatic event where they have to have a surgical repair. They're exposed to an opioid analgesic, and they can have a very different reaction than someone who doesn't have that same type of history. So there are vulnerabilities. The first and foremost, it is age, but it is also having had any other type of substance use disorder increases your vulnerability to opioid analgesics. And the connection between opioid analgesic addiction or use disorder, and the connection between the opioid analgesics and the use of heroin is they're affecting the same parts of the brain. They're the same drug in different forms. And heroin is much less controlled than a prescription opioid where that's been given to you by a doctor, presumably for a circumscribed period of time at a particular dosage. However, the same parts of the brain are affected. And if you have a vulnerability or you are receiving the medication for too long a period of time, or if you're at very high doses, you're at risk of becoming addicted. And when someone becomes addicted, the cost, as we've heard of heroin, is very low. And the cost of opioid analgesics on the street is very high. And so people can quickly convert to using heroin. Recently there was an article that pointed out of new heroin users, 3/4 of those new heroin users started off by using, with non-medical use of opioid analgesics. So that doesn't mean that their doctor prescribed them. That means that they were taking them recreationally. But the conversion to heroin happens far too frequently. And you can die from either type of overdose. In both cases, you end up another statistic. And last year in 2014, there were 504 opioid-related overdose deaths in the state of Connecticut. And the estimate is that for 2015, that number will go up to 619. That's despite the efforts that we've heard about trying to quell this storm. We've heard a little bit about the prototypical addict is not the prototypical addict. And this isn't an inner city problem. This isn't a problem for people who are impoverished. But it's important to be alert and be on the lookout for people who are struggling with this disorder. One of the things that we also heard a little bit about, but at Rushford we have been focused on for a number of years, is getting the medication naloxone out into the community. And naloxone is the opioid overdose reversal medication. It's very safe unless your neurotransmitters are filled up with opioids. You probably won't have any reaction at all if you're given this medication. Now, with the signing of the law over the summer, certified pharmacists can write prescriptions without a doctor's order. And there have been programs in place since 1996 which provide opioid overdose education for communities and readily give out naloxone. And because of those programs, the studies have shown there have been over 16,000 lives saved. So if there's one thing that I'd like to get across tonight, it's let's try and take advantage of the opportunity to get naloxone in the hands of the people that can benefit from it most. People who are using these drugs and are addicted to these drugs are around other people who've been addicted. I saw a 19-year-old a couple of weeks ago who came in for treatment of her heroin disorder, and she told me that she had overdosed over the summer, and that someone at this party she was at had used naloxone to revive her. And I found out after talking with her a little bit longer that her father had died of a heroin overdose a year earlier. He wasn't as lucky. It's important to be looking for this disorder. There's a program called excerpt, and it has to do with screening, brief intervention, and referral to treatment. And screening is asking a few simple questions. This could be primary care providers, and this can be done in other settings as well, that have been shown to help and detect people who may have a substance use disorder or be using substances in a dangerous way. This could be for alcohol, this could be for marijuana, and this could also be for opioids. So it would be very important. The American Academy of Pediatrics actually, they came out with a position paper. They feel that all pediatricians should be using screening and a brief intervention for their patients regularly at all visits. And I think the same should be happening for primary care providers and family practitioners, and we'll be hearing from a family practitioner in a couple of minutes. To circle back and address question number 2, which is why are people using these drugs? It's because people have become addicted, and addiction is a chronic and recurring disease of the brain that affects the neurotransmitters that control impulse and can then affect your memory and your motivation. That is one of the reasons people are using, because they can't stop. Thank you.
Thank you again. So I'm Dr. Huddleston, and I've been a family doctor here at the Community Health Center for the last 15 years, at first in the old bowling alley behind the soup kitchen, and more recently in this building. When I heard about this forum, I was really excited to be a member of the audience. But I think it is fitting for a family doctor to give a perspective in primary care, since we are part of the solution and we are part of the problem. Sort of an increasing awareness, as Rosa DeLaura mentioned. Between 2002 and 2013, heroin use increased by almost 300%. Through that same period of time, the prescription of opioid medications increased almost 400%. And so you look at this graph, it's going up like this, and then the non-medical use of opioids kind of goes like this, overdoses, and heroin goes like this, and you say, well, why is that the case? And so this kind of answers, where do the medications come from? Now, one reason, I went to medical school out in San Francisco in the 90s, and there was a burgeoning realization that we in medicine were doing a crummy job taking care of people in pain. And that's part of the reason we have these fifth vital sign. You go to the doctor, they say, from a scale of 0 to 10, are you in pain? And we're going to try our best to do this. And so part of addressing it aggressively was the idea that when necessary, you go up the World Health Organization ladder, and at the top of that ladder are these opioid medications. These are really potent, very strong chemicals, all related to opium. And this is like the fentanyl we're talking about, and the morphine, and the diacetyl morphine, which is heroin, which in other countries is used as a pain medication under controlled settings. And so we say, we're going to use these medicines when we need to. We need to try to do a better job relieving suffering. And then there was the idea that went along with that in the early 2000s that if you've made the decisions after a history and a physical exam that somebody has a terrible thing happening to them, and it's a grim truth in primary care, and I'm going to recognize it to myself, that bad things happen to us eventually. So you've made this decision, you're going to treat it. There wasn't a ceiling dose. You would go up on the dose until either the pain was relieved or you have other side effects. You know, and then the realization more recently in the last 4 to 5 years saying, okay, we have these graphs, but if you superimpose upon that graph, what is the level of suffering and disability reported amongst people during that time? And it hasn't changed. We haven't really seemed to help people. I think that's a positive looking sort of in the last couple years. The CDC has a draft proposal for the use of these strong pain medications in non-malignant pain. And they have a lot of the things that we're kind of talking about. So how do you prescribe stuff in a smart way so it doesn't end up in one of my patients' blenders so that you can snort it afterwards? And you know, we have things like controlled medication agreements and frequent drug screens. And I've grown a little bit about having to check the prescription monitoring program, but that is so much better than what it used to be, where if I had somebody in trouble, I would call down to what was then Pelton's and talk to the pharmacist and say, what is this guy getting? And then I would call CVS, and then I would call Walgreens, trying to do these fishing jobs to make sure that I was doing a safe job taking care of somebody. So, you know, focusing on the problem a little bit, you know, the guy who used to blend up the Percocet, well, where did he get the Percocet? Where was that from? Or I had a patient who came in with foot pain. And I was trying this and I was trying that. And finally he pulled out a fentanyl lollipop and said, yeah, but this works. And after my jaw drops and I think, well, where did that come from? And then, well, where did it come from? If I could follow the path of that lollipop, which really should, in that formulation, only be used at sort of kind of really end-stage hospice when you can't swallow anymore. It's a really potent, dangerous medication. But if you follow the path from hand to hand, well, it came from a pharmacy. And then, you know, so how did the pharmacy release it? Well, it came from a doctor. And so if I'm serious about treating pain, I need to do it in a smart way. But I also need to do it in a way that my medication, ideally, and you can't control this, unfortunately, 100%, but ideally does not go wandering and cause people damage. So working here in Middletown, I don't know, my own practice ended up sort of shifting towards folks that are struggling with HIV and hepatitis C and a little more with addiction. We've always had addiction in Middletown. It used to be a little more crack cocaine. When I first started, people were using heroin, and they'd been using heroin since the 60s and 70s, so it's like a bunch of old guys using heroin. And then we had the synthetic marijuana, which thankfully went away with the past. And we had the bath salts, which thankfully got legislated out of existence, so they weren't being sold in the gas stations. But now really pills, lots and lots of pills. And so how do we approach that? A few of the things that I am most excited about, well, one is trying to get buprenorphine, Suboxone treatment into the community. Dr. Lecce, who's here somewhere, and I have been doing this for about 5 years, and really kicking and screaming. You know, we're family doctors. I take care of kids. I take care of old people. I take care of people with diabetes. And I really want to do this, but seeing people just not getting the help that they needed. They couldn't get to a methadone clinic. We don't have a methadone clinic in Middletown. It's a full-time job if you're on methadone. You've got to take, however many buses every single day to Hartford or New Britain. And so we started doing it. And you know, the benefit that you get. So I had 2 roommates. They were both using lots of things, but mostly heroin and pills. And I just couldn't get one to make the program stick. He would come positive with cocaine, he was selling his medications, he was using, he wouldn't come in, he wouldn't come out. And finally I said, well, this is not working. You need a higher level of care, and tried to point him towards you and towards whatever inpatient. And the other one, the program kind of stuck. And if you look at their 2 paths, the guy that didn't stick with me, about a month later, he overdosed and he died, and he's gone. And the guy who stuck with me, you know, there's some bumps in the program. Addiction is this chronic disease, you know, like diabetes. Sometimes you're having good control and sometimes you're having a little slip. But he's really done well. He hasn't used drugs, as far as I know, in several years. He has a job, he has money. I recently treated him for hepatitis C. His hepatitis C is cured. He's living his life. So getting buprenorphine out into the community is one solution. The Community Health Center has done some great things, like this teleconference series, to try to get other prescribers comfortable with the idea of how to do this in a safe and effective manner. Decreasing how much we're prescribing, so that ceiling effect, that's no longer, the absence of the ceiling is no longer accepted as true, and trying to keep our prescribing down. So it's been shown if you're prescribing more than 50 morphine milligram equivalents, you are increasing the chance of people having motor vehicle accidents, of dying, of overdosing. You aren't necessarily helping anything. And I would love to get the naloxone out there. I have tried. I think Massachusetts is doing a really admirable job with that. And there's some economic problems. Insurance isn't covering it, I'm finding. We have the needle version, which is relatively inexpensive, but I don't like the idea of having needles out there, and people are shy of needles. There's the nasal spray attachment, which is a wonderful way to do it. You don't have a needle, you just stick it in their nose, it goes zoom. The FDA recently approved one, which is 5 times the cost of a regular bottle. And what you need to do is you have the little nasal spray that you can order, like 100 of them for really cheap, and you just put them on the other thing. But getting, again, the insurance to cover it, and people don't have money, it's hard to get it out there. But I am hopeful that we have some positive directions to go. And I still wish I was in the audience. But